be having Miriam Edeh, and she will be talking to us about the theory for improving children's health, a case for their deworming program. So, a brief biography of Miriam. So, Miriam is a result-driven development expert with over 10 years of leadership and program management experience working with international NGOs across Nigeria. Before joining Evidence Action, she worked on maternal and child health and nutrition projects funded by USAID, WHO, Save the Children, BMGF, and other private sector donors. Currently serving as the senior manager of the Southeast Zone at Evidence Action, she's responsible for providing strategic program management and leadership support to multiple program implementation in the region. Can we give a round of applause for Miriam as she walks the stage?
Good morning, everyone. I hope we're all doing well and happy to see everyone today, day two of this conference. Just quickly saying a special thank you to the organizers, Zachary and his team. And we're happy as Evidence Action to be part of this very interactive and enlightening summit. So, like he introduced, thank you to Kenneth. I'm here to share our learnings and successes around the school deworming program at Evidence Action. So, in our daily lives as individuals, we all have a story to tell from our past experience, our life in general. But today, Evidence Action will be sharing Abike's story. By introduction, Abike is an 8-year-old child who hails from Afijio very rural community in Oyo State. And basically, this story is centered around how Evidence Action has been able to improve child health through our theory of change. So Abike is a school-age child, 8 years old, like I earlier mentioned, from a very rural community in one of the geographies where we program. Abike plays outside, barefooted. In fact, she has to walk a distance of 2 kilometers to access her school on a daily basis. And that she does without shoes. Again, in her community, Abike and the community members engage in open defecation. They do not even practice hand washing activities. Abike also falls, for this reason, she gets sick a lot of times. And this has also led to absenteeism in school. She's unable to attain, she's unable to perform well in school. She struggles to stay through school for the whole term. Again, Abike, as a school-age child, always complains of issues around stomach ache. Again, she suffers from anemia. You can see from her look and everything, she's small for her age, and she has also not been progressing in school. Abike and her community also relies on a nearby river or pool for the use of the water, maybe for drinking purposes, household use purposes. And the list goes on for this young child, this school-age child, Abike. You may want to ask, what exactly is happening to Abike? Abike, with her seemingly promising future, is suffering from parasitic worm infections. And parasitic worm infections like schistosomiasis and soil-transmitted helminths are classified as neglected tropical diseases. They are under the umbrella of neglected tropical diseases, for short, NTDs, which is a diverse, WHO has defined this group of diseases as a diverse set of conditions that affect over 1 billion people globally. Children are most vulnerable to this infection. And The result of the outcome of this disease in the life of a child is that the child is malnourished, has poor immunity, and even cognitive development. You see that the child is stunted and, most importantly, unable to attend school. For adults, we hear of cases of disabilities. These adults are unable, they are socially excluded, they are unable to work, and a host of other issues or challenges that are centered around mortality. Ultimately, this kind of diseases affect the poorest of the poor. We would see how this data also cascades to Africa and Nigeria as a whole. So when we say neglected, what does it mean? We see that there is the issue around funding. The efforts to control and eliminate this disease lacks the sufficient investment. So the question would be, is the government prioritizing this? Why exactly are these diseases neglected? Another reason is that because these populations that are affected by this disease have a low power, their voices are not heard, their needs are often neglected by governments. I'm sure in the room, when I ask how many of us have heard of neglected tropical diseases, we would see how well known these diseases are. Again, they are absent from global health agendas. These things do not come to the front burners. The discourse around it is always limited. The government, we see global agendas focused on other big, in quotes, priority problems like HIV, malaria, COVID. There is no urgency around neglected tropical diseases. So just quickly diving into what the global data says and the national data. WHO has noted or has estimated that more than 1.6 billion people require interventions against NTDs as of 2022. Again, 19 billion have the disability adjusted life years lost to NTDs. 632 million school-age children require treatment for one of these NTDs, which is a soil-transmitted illness, the parasitic worm infections. We see that 264 million people require treatment for schistosomiasis. And then coming down to our country, Nigeria, over 1 million Nigerians are at risk of these infections. Again, if I ask us here, seated in the room, for those of us who have children, how many times have you dewormed your child this year? Even as an adult, when last did you take a deworming medicine? I guess we'll all be excited to hear what the response is. And then in Africa generally, Nigeria accounts for 25% of this disease burden. So we begin to see that NTDs is something that actually needs attention. It's just that, again, could it be a case of people are not aware that this is a disease that requires attention? Let's talk about the negative impact of these parasitic worm infections. So we see that these infections cuts across three key pillars in the life of a child and individual. And under health, we're seeing that these worms compete with the nutrients that the individual, or let's step it down to the school-age child. That school-age child requires for growth and development. It competes with the child's needs, and thereby leading to malnutrition, leading to anemia, and impaired cognitive development. This child is unable to, most of the time you see the child is either small for age and does not measure up with his or her peers. In the area of education, this is so critical. I hear the education stakeholders a lot of times talk about the need for school retention, school participation for every learner. But the question is, when a child is sick, can they stay in school? Will they learn? When a child is sick, or when a child is affected by these parasitic worms, the child is often too sick and tired to remain in school. So you have issues around um, absenteeism, you have issues around poor performance. And then for livelihood, the worm infections during that child's life decreases the productivity and results in low wages in adulthood. And would be the next slide shows would quickly be looking at, by the time we get to the slides after this, we'll look at how evidence, the research that has taken place in some geographies within Africa points to this. Overall, this reduces the economic opportunities for such an individual. So, what is our solution as an organization? What solution are we prioritizing? What solution are we bringing to the table as an organization? Mass deworming has been recommended by the World Health Organization. And when we say mass deworming, it's providing a safe single dose medication of deworming tablets to all the children at risk of these diseases. Data is also available to show that, yes, children truly require this treatment. And when the medication is available, we then use a multiple delivery approach where we're engaging basically with existing structures. That's the school and the health system to deliver the medicines safely to the children. Each treatment delivered to a child on an annual basis, based on our model, just costs $0.50. Going by the current rates in Nigeria, $0.50 is like 750 naira. So our model as an organization shows that with 750 naira, you can deworm a child and give the child a good start in terms of education, health, and livelihood. And then taking into account the health, education, and economic outcome of every given child, deworming is considered as a cost-effective intervention, a best buy for development, showing that there is a 37% reduction in investment, especially on the side of the government. So why are we not prioritizing this? Just quickly highlighting some of the evidence that we have seen. The Deworm the World initiative is based on a robust evidence that shows deworming has immediate and long-term impacts. So researches were conducted in a country like Kenya, and the results showed that children who received deworming tablets had a 25% reduction in school absenteeism. And when this is the case, ultimately you expect that school performance is also improved. Same children were also followed for 2 decades later. And research also showed that they had increased outcome, meaning their livelihood improved. So this is a case for deworming. For evidence action as an organization, we'll move into who we are as an organization and what our projects are currently in the country. So as an organization that focuses on improving the well-being of people generally, we're constantly ensuring that we scale up programs that reaches millions and millions of people. We invest in what has proven to work. We're an evidence-based organization, like our name implies. Our approach creates big impact with the lowest cost. This is where cost effectiveness comes in. We're more focused on projects that we can scale, projects that are evidence-based and scalable. We leverage rigorous research. Our name again validates this. We go to where the evidence is, And then we address interventions that are neglected, in quotes. We also develop and pressure test our low cost delivery models. We ensure that we develop partnerships and garner investments to scale them up in an unprecedented way. Our focus is majorly, as an organization, our focus is majorly on health, nutrition, and safe water. One of our presenters yesterday talked about the dispensers for safe water in Kenya, and that's one of our major projects at Evidence Action. We're currently in Africa, Africa and Asia, and we're so far with interventions focused on health, nutrition, and safe water. We have been able to reach over 250 million persons in these 9 countries. Our strength as an organization, we focus on interventions that are scalable. We build strong relationships. One of our major approach is to provide customized technical assistance to state governments, meaning that when we move into a geography, we have to leverage existing structures. We deepen our relationships with government partners. We do not implement directly. We also rely on rigorous, without the evidence, we would not, we would not move forward with the work. We're focused on delivering excellence in everything we do, looking at our cost effectiveness delivery models, strong performance on key program indicators, and also our last mile distribution approach. And then we don't compromise standards. If the program does not meet the standard, we're out of it. With this, our value is that we continue to emphasize evidence first. If the evidence, we go where the data is, we go where the evidence is. If it doesn't exist, you can't find us there. We also think big and act urgently. We iterate again. So we are not afraid to look at things the way they are and think of how we can make it better. And then we economize without compromise. We're big on cost effectiveness of our programs, and we make sure that while we're thinking about the cost effectiveness of the programs, we do not compromise standards. And then we challenge convention. We ask why and why not. Why does it have to be this way, and how can we improve on it while maintaining our passion throughout the journey? Just highlighting some of the health, nutrition, and safe water programs we had talked about. This is a snapshot of all our interventions across the geographies where we work, the 9 countries. So we have the Safe Water Now intervention that cuts across several geographies where we work. And so far, this intervention has provided over 10 million people in rural communities, underserved communities, with access to safe water through chlorination, whether it's liquid or solid chlorination, and at a cost of $1.50 per person per year. So we also do cost effectiveness estimations for all our programs, all the programs at Evidence Action. We have the Syphilis Free Start intervention, where we're saving newborn lives, working again with the government. Like I said, our focus is providing customized technical assistance to the government partners to roll out these interventions. And this Syphilis Free Start helps the government provide low-cost syphilis screening and testing for pregnant women. At Deworm the World, we help the government deliver over 1.8 billion deworming treatments in the course of the number of years we have worked in the geographies where we are, at a cost of $0.50, which is 750 naira per treatment on an average. And then the last one is the equal vitamin access, where we help government tackle issues around micronutrient deficiencies, preventing anemia in children and adolescents. So, evidence action has been existing since 2014, and we have our impact is clear. We have been able to reach over 2 billion persons with the deworming medicines, especially children across all the geographies where we work. And like I earlier mentioned, at 50 cents, half a dollar. Looking at how our customized technical assistance model is provided, we work closely with the government to maximize the long-term impact at scale. And how do we do this? We provide policy and advocacy support by helping the government establish structures and embed the deworming program policies in their departments. We're also supporting the government on resource planning, where we work with the government to create targets, operational plans, and budgets that align with domestic resource mobilization. We ensure a last mile distribution of the medicines such that the medicines are able to move from the highest points to the lowest points, which is the schools and communities, through the existing platforms, the schools and the health centers. And then there's the real-time monitoring and evaluation that helps us monitor, track, and identify challenges, and also generate evidence that keeps the program going. Then we have the training and capacity building part. We have to continue to build the capacity of the government to take up the program even after the funding we are done, the funding is gone. So we work with government at multiple levels, at the state level, at the national and sub-national levels, to ensure that we create an efficient, multi-layered training cascade. And then finally is the community sensitization approach, where we make sure we support the government to provide locally tailored campaigns that speak to deworming. So for Deworm the World, this is our impact so far. For over the past decades, we've been working 2 billion deworming treatment delivered, which has amounted to productivity gains of over $23 billion. And then we have also, in this, we have reached over 500 million children with deworming tablets on an annual basis. And that has also reduced the disease burden, the worm prevalence of these children in the geographies where we work, to the tune of over 70%, seeing that we're able to deliver each treatment at a cost of 50 cents. The worm prevalence rates have dropped significantly in most of the geographies we've worked, and this is evidenced by the impact assessments that we usually conduct after 5 years of effective treatment or deworming. We had a case in Kenya where we conducted the most recent impact assessment, and it showed a reduction from 32% in 2012 when we started to 6% in 2022, which is an incredible reduction. In Nigeria, we also conducted the same impact assessment in Rivers State, which is one of the states where we work, and we saw a 70% reduction of the worm burdens after 5 to 6 years of deworming. So as an organization, what is our theory of change and our impacts of deworming in the country? So just quickly looking at our theory of change, our focus is basically to reduce the disease burden and to strengthen the health system and government structures for a long-term sustainable program. At the center of our programs, we're thinking sustainability. We're not implementing to continue to promote over-reliance from the local communities. We're working closely with government, all the arms of government at the national level, subnational levels, to make sure that the program remains sustainable even after we're gone. And how are we able to achieve this? We're providing effective training, capacity building opportunities for teachers, health workers. We're also ensuring that the government is fully involved in the drug procurement and supply chain management. Where along this, the inputs we're providing, we're ensuring that we're holding the hands of the government to make sure that we deliver the right intervention. And part of what we're also doing is strengthening the system that already exists. So for Nigeria, the deworming program started in 2016 in collaboration with Ministry of Health, Education, and SUBEB. Remember that we continue to talk about collaboration, and seeing that the deworming program has a direct impact on education. We're not leaving the education stakeholders out of this intervention. So the partnership, for every geography where we work, we sign a tripartite agreement between we, the partner, Ministry of Health, and Education to ensure an effective collaboration. And so far, on an annual basis, we're able to reach 6 million children, target and reach over 6 million children. We collaborate with the education sector to deliver treatments to over 27,000 schools in the 5 states where we work. The 5 states where we work are Lagos, Ogun, Oyo, Rivers, and Cross River for now, for the deworming program. We also provide logistic support to ensure that on an annual basis, over 9 million tablets are distributed, even down to the last mile. Then we ensure that the training cascade happens at different levels of government, from the state level down to the local government level and the school community levels. We collaborate with government to train teachers, community drug distributors, and health workers to ensure that no child is left out, particularly for states like Rivers and Lagos that are urban states and have pockets of hard-to-reach communities. This strategy helps us to reach children in the most difficult-to-reach areas. And like I earlier mentioned, we recently conducted a prevalence survey in Rivers in 2023 after 6 years of effective deworming. And the report shows that the prevalence of STH has decreased by 70% from the deworming that has been happening there, which is a great feat for us. Here are some of the pictures of just bringing this home. These are some of the pictures of the worms that are expelled as soon as children ingest the medicines, to drive the story home and show how real neglected tropical diseases are. These are roundworms, particularly soil-transmitted helminths. So evidence action is and will continue to give millions of children like Abike a chance to reach their full potentials by tackling the neglected tropical diseases that affect poor communities, neglected communities. And based on our evidence and impact so far, we have been trusted by several high impact charities, such as what you can see on the board. We have been recognized by several publications and several publications by these listed charities. We have come to the end of my presentation, and I hope you learned one or two things from it. Yes. Thank you.
Thank you so much, Maryann, for the incredible session. It's really inspiring seeing what you guys are doing, and I will give you kudos to that.
Thank you so much for the wonderful presentation. Like you said in your presentation, the state you are currently working I realized we have none from the north. And my question was actually to ask you, do you have any the one program currently running in the North Nigeria? But from your presentation, I realized you're not even existing in the North Nigeria. So are you planning anytime soon to move to the North? Thank you.
Okay. Thank you very much for that question. So for the NTD program in Nigeria, there are several partners that are currently in that space. Evidence Action is just one of the partners, and we are prioritizing the states that evidence has shown us that they really need this support. In other states across the country, there are other partners working in the same space. I can always point you to them if it's something of interest to you, but I can assure you that across the 36 states plus one, there are partners who are also deworming in those states. Yes.
Okay, thank you so much, Miriam. Due to the want of time, I think this is where we draw the curtains for the session.